Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and to delve into the challenges and impact each technology has in practice. This is the Medtronic Med-Ed learning experience. The BIS monitoring system should not be used as the sole basis for diagnosis or therapy and is intended only as an adjunct in patient assessment. Reliance on BIS system alone for intraoperative anesthetic management is not recommended. Medtronic's medical education programs are offered to provide attendees education on the FDA-cleared indications and use of our products when applicable. The contents and conclusions of the following program are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers received funding from Covidien LP, a Medtronic company, for the speaking engagement. For this segment of the series, a discussion on anesthesia in the brain, we will discuss how BIS monitoring can be used with other traditional monitoring parameters during anesthesia management. To help provide insight into this topic is Dr. Stephen Bader, Chief of Cardiothoracic Anesthesiology at Heritage Valley Health System in Beaver, Pennsylvania.
So the BIS gives us another piece of information in addition to the traditional parameters that we all learn in training of how to sort of determine where the patient is on that light, adequate, deep spectrum of anesthesia, whether we're talking about sedation, for moderate sedation type cases, or whether we're talking about general anesthesia. I think we're all very familiar with those traditional things that you would use to determine. And it's hard when you're a trainee and you're first learning how to sedate people. How do I know if I'm overdoing it? There's this tendency to be very heavy-handed with sedation cases. So if I'm going to perform a colonoscopy where I need the patient to be sedated enough that they don't remember anything about the procedure, but not so deeply sedated or provided with so much opioid analgesic that they stop breathing or have profound hypotension from me giving them massive doses of propofol, for instance, which would be the most common thing for colonoscopy. So if I have a BIS monitor on a moderate sedation patient, I have a little more confidence, depending on my level of experience. I have a little more confidence to give less of the anesthetic agent, knowing that I can see their BIS number is low enough. Especially, with experience, you'll identify as you're starting to sedate the patient, oh, this guy is needing a little more, right? So in addition to my traditional, I see that he's moving or that he's breathing really quickly or his heart rate's rising whenever they start to stimulate him with the scope, or, passing it a little more deeply or making it around one of the turns in the colon, you'll anticipate clinically that there's going to be stimulation, and then we look for those traditional clinical signs that maybe the patient is too light or maybe the patient is too deep. If they're moving around, they're too light. If their blood pressure is really low and they're stock still, they're too deep. So having the BIS there confirms that, and also allows me to sort of suss out this patient's individual response to my drugs. And so that's sort of the biggest thing. If I teach a new resident how to provide sedation for colonoscopy, they're all going to want to give every patient exactly the same drugs because it's what's most comfortable. But you don't really have any way of knowing how those drugs are affecting each individual patient until you see what happens. And one of the things that you can now monitor is, your processed EEG with the BIS. It gives you an actual end organ measurement of what you're trying to infer with those traditional physical findings of hemodynamics or the patient moving. So I think it has tremendous value in, helping trainees, especially with moderate sedation cases, be more confident to not overdo it so much. Now, with general anesthesia, I think there's still that same phenomenon with, a discomfort with having the patient be too light. So the traditional things that we would look for under general anesthesia, we talk about lacrimation and sweating, signs of sympathetic activation that the patient, really looks light just by those things. Obviously, movement is something that we all worry about under general anesthesia. And if you have the patient paralyzed, movement is taken away from you as an assessment tool. So that's one of the reasons that we frequently talk about BIS being particularly valuable in patients who have gotten muscle relaxant, right? Because you've taken away one of your most potent awareness monitors by taking away the patient's ability to move in response to painful stimulus. So trying to organize my thoughts a little bit about, the traditional things under general anesthesia that we talk about would be those physical signs of movement or lacrimation, sweating, but then the hemodynamic parameters. And, that's where you can really get into trouble with trying to, teach someone how do you know if these hemodynamic changes are reflective of your anesthetic state or of something else. So traditionally we'd say, well, the patient has a high heart rate, they're tachycardic, or they have high blood pressure, and it's coinciding with a painful stimulus. So you'd infer that that reflects, not enough anesthetic agent or not enough analgesic agent. And now you have the BIS number as a confirmation of that. You could also have hypertension or tachycardia from underventilating the patient, and they're becoming hypercapnic and causing sympathetic activation that has nothing to do, with surgical stimulus or with, an inadequate analgesic dose. It has to do with me not ventilating the patient enough. So having the BIS as this objective end organ monitor of the brain, even though it may not always tell you exactly what you think, you have to understand the pitfalls that go with that number. I think that it does provide you with a really valuable adjunct. So the other way to think of, using it is with hypotension and bradycardia, right? So we talk about hypertension, tachycardia, or tachypnea. The patient starts to breathe really quickly if they're not, in a general anesthetic with muscle relaxation. Those are all signs that the patient might be light, that you could measure their numbers on the monitor. And then now you have this additional, number on the monitor that you can correlate to the rest of the clinical picture. So with deep anesthesia, we assume a low heart rate, lower blood pressures requiring pressure support, and maybe apnea if you have the patient not paralyzed and spontaneously ventilating. You can infer from those low numbers that the patient is too deep or has too much analgesic on board, and correlate that to the clinical situation. Now, if I also have the BIS and it's reading 20 or 10, I have real confirmation that hypotension is being caused by deep anesthesia and not by unseen blood loss, or I'm getting behind on my fluid resuscitation, other reasons that the patient might be hypotensive. So I think that especially for trainees, it's really helpful to have that additional piece of information. You just have to make sure that you understand to correlate it with the rest of the clinical picture. So there's a tremendous amount of value in having that additional number. During emergence, we frequently see coughing, patients bucking, all those things that happen during the lightening up phase of emergence. And you can anticipate those things and try to prevent them if you have, an additional piece of information. That you're turning down the anesthetic as the patient is, getting their dressings put on, and you're starting to get a little anxious. They're going to start jumping before everybody's done with that last stitch or that last piece of bandage. Having the BIS there makes you a little more likely to anticipate that coughing that you don't want to happen by keeping them just right until it's time to fully emerge. So I do think there's tremendous value there in having an additional monitor to the traditional parameters.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.